Infants suffering a hypoglycemic event within the 4 hours after birth decreased from 22.7% in the control group to 10.2% in the intervention group. So how does skin-to-skin contact help? It involves placing the infant prone on the bare chest of the mother soon after birth. UNICEF's baby-friendly initiative guidelines suggest that this duration of skin-to-skin contact should be a minimum of 1 hour or until the first feed is complete. It promotes physiological stability in infants, early and exclusive breastfeeding, and parent-infant feeding. Preventing hypoglycemia. This prevents hypoglycemia by reducing the infant's energy expenditure by promoting thermoregulation. Thereby, only lesser energy is required to maintain the infant's body temperature. It also increases the quiet sleep time and reduces the crying. Both of these effects have been found to persist for at least 4 hours following the skin-to-skin contact, and this also promotes early breastfeeding initiation. So the title of the study was Skin-to-Skin Contact for the Prevention of Neonatal Hypoglycemia, a systematic review and meta-analysis published in 2023 in the BMC journal. So they proposed their hypothesis as to examine whether the skin-to-skin contact is effective in preventing the neonatal hypoglycemia compared to standard care or other treatments. It was a systematic review which included articles that was published till May 12th, 2023, and the trial was registered prospectively in Prospero with the registration number as mentioned. Population included both preterm and term hemodynamically stable babies. Intervention was standard care with skin-to-skin contact commenced any time during the initial hospitalization after birth. The control arm was a standard care without skin-to-skin contact, and outcome is as mentioned in the next slides. So they included studies that were published randomized control trials, quasi-randomized control trials, and non-randomized studies of interventions, cohort or case control studies, where the intervention was standard care with skin-to-skin contact, and the comparator was standard care or other treatment without skin-to-skin contact. And the exclusion criteria were trials that compared the newly introduced skin-to-skin contact to a historical standard care data, because it will be difficult to ascertain what other differences in practice could have occurred between the two time periods. Outcomes. The primary outcome that was measured was neonatal hypoglycemia, and the secondary outcomes measured were hypoglycemia during the initial hospital stay after birth of less than 2.6 millimoles or 46 milligrams per deciliter, receipt of treatment for hypoglycemia, which included oral dextrose gel, intravenous dextrose, or other drug therapy during the initial hospital stay, number of episodes of hypoglycemia, severity of hypoglycemia of less than 2 millimoles or less than 36 milligrams per deciliter, admission to NICU for hypoglycemia or hypoglycemic injury on brain imaging, hyperthermia or hypothermia, duration of initial hospital stay after birth, and breastfeeding exclusively from birth to discharge, breastfeeding exclusively at discharge, and adverse effects of skin-to-skin feeding, skin-to-skin contact. So their search databases included the three major databases, which is the Medline, Embase, and the Cochrane's Central Register of Controlled Trials from their inception point to the May 12th, 2023. And also the search included the registered trials in current controlled trials, clinical trials, Australian and New Zealand Clinical Trials Registry, and WHO's International Clinical Trials Registry Platform search portal. They did not mention the keywords or their exact search strategy in these databases. So the flow diagram of the included studies were records identified from databases were 9,053 and registers were 240, and the duplicate records were removed. Further, 5,140 records were screened, and 418 records were sought for retrieval. 400 records were assessed for eligibility, and 226 were excluded because of wrong outcomes, study design, wrong comparator, intervention, timing of intervention, population, setting, or if the result was not available or if the study ceased early. Finally, a total of 108 reviews plus 8 ongoing studies, that is a total of 116 studies were included in the review, of which the records were 163 plus 11. records were included in the study. So there were 65 RCTs, 16 quasi-RCTs, 7 non-randomized studies of intervention, 8 prospective cohort, 9 retrospective cohort, and 3 studies which were case control. Data collection and analysis was done by 2 independent reviewers who assessed the risk of bias in the included studies. Discrepancies in any step were resolved either by discussion among themselves or with a third author. All the included RCTs or quasi-RCTs were assessed by using the Cochrane's Risk of Bias Tool 1. And EPHPP, that is the Effective Public Health Practice Project Quality Assessment Tool, was used for assessing bias in non-randomized studies of intervention, cohort, or case control studies. Certainty of evidence for key outcome was assessed by using the grading of recommendations, assessment, development, and evaluation approach. So the risk of bias that was used in this study is the Cochrane's Risk of Bias tool. So it assesses the following biases to see and grade each study on their risk of bias. So it screens the articles for sequence generation and allocation concealment, which will be included in the selection bias, whether the participants and the personnel were blinded or not, which will be seen in the performance bias, and detection bias to see if the outcome assessment was blinded or not. If there's any incomplete outcome data, it was included in the attrition bias. If there was a selective reporting of only significant findings from the study, it was included in the reporting bias. And all these biases were classified as low, high, or unclear on the basis of presence or absence of these process. So the risk of bias tool and the risk of bias that was obtained in this systematic review is shown here. So the green color represents the low risk of bias, yellow is the unclear risk of bias, and red is the high risk of bias. So if we see, all the studies were compiled and they were their bias was assessed in each of these category. Predominantly, we can see that most of them had an unclear risk of bias. So grade assessment is a type of assessment that describes the process of rating the quality of the best available evidence and thereby developing healthcare recommendations following the approach that is suggested by the grade working group. So clinical practice guidelines offer recommendations for the management of clinical conditions. In order to help the clinicians make an evidence-based medical decision, the guideline developers often will grade the strength of their recommendations and rate their quality, informing those recommendations. So the grading is generally as very low, low, moderate, or high. The quality of evidence is evaluated on the basis of the study limitations, inaccuracies or imprecision in their data, incompleteness of the outcome data, indirectness of the evidence. That is, if the skin-to-skin contact was not exactly mentioned as skin-to-skin contact or rather included as a part of kangaroo mother care, and risk of publication bias. So based on these categories, the evidence will be collected, assessed, and they will be reported reported in the format of grade. Statistical analysis. The meta-analysis was done using the statistical software of Raveman 5.4.1 using the random effects models. Relative risk or odds ratio with 95% confidence interval was calculated for the dichotomous outcome variables, and mean difference with 95% confidence interval was calculated for continuous outcome. Stata 17 was used for pooling the adjusted odds ratios from cohort and case control studies. A p-value of less than 0.05 was considered statistically significant. So since this was a systematic review, it was important to see how much heterogeneity that was there. So I-square and chi-square study was calculated to determine the statistical heterogeneity, and an I-square more than 50% and a p-value less than 0.1 in chi-square was considered to be having a significant heterogeneity. And publication bias was assessed by the visual inspection of the funnel plot, plotting the study effect size against the sample size. And this funnel plot was uploaded as a separate annexure file. The results of the systematic analysis is represented in a graphical representation in the form of a forest plot. So if we see in this graph, we see 7 lines here, which represent 7 studies. Each horizontal line represents an individual study. And the squares on this horizontal line is the odds ratio of the study. And the area of the square or the size of the square represents the weightage of that particular study to the meta-analysis. The ends of the lines will represent the 95% confidence interval, and in between we see a vertical line which is showing the risk ratio or the odds ratio of 1, which is the line of null effect. So if the confidence interval of the study includes this odds ratio of 1, it means no significant difference was found between both the groups. And summarizing or compiling all these study data, a diamond is collected, which represents the odds ratio, and the ends of the diamonds will represent the 95% confidence interval across all the included studies. So it is important to see whether the studies have a similar result, or if at all there are different results, we have to understand why it is. So this is done by using heterogeneity. So when the results of the pooled studies are different, we need to know whether it is due to bias or actuality. Even if studies are clinically homogeneous, they may be statistically heterogeneous. So this can be caused by clinical differences between the studies, methodological difference, or unknown study characteristics. So three types of tests are employed to see the heterogeneity in any systematic review. It includes the forest plot, chi-square, and Higgins I-square test. So in forest plot, if we see that the confidence interval of the studies are overlapping, it means that they share some amount of homogeneity. And for chi-square, as seen before, a p-value less than 0.1 will be considered homogeneous. And for Higgins I-square, it reports a quantitative amount of heterogeneity by percentage. Any value more than 50% is said to be significant heterogeneity. So moving on to the results of the study. So if we see the effects on hypoglycemia, there are two charts represented. The A chart, or the first chart on the top, shows the results from the 7 randomized studies. Next to the study title, we can see that skin-to-skin events and total and control events and total are mentioned, which includes the number of studies, and the events include the number of hypoglycemia babies. Next to that, we see that weightage of each study that is contributed to this meta-analysis is represented in percentage. And the next column is the risk ratio. So if we see the effect of skin-to-skin contact on hypoglycemia, the overall risk ratio is 0.32, that is, which is significant. And if we see in the forest plot, we see that 3 studies or 2 studies predominantly have a significant odds ratio, and they do not cross this line of null effect. And the overall odds ratio is 0.32 with the I-square of 45%, so which is less than the 50% as proposed by them initially. The B chart represents the non-randomized study. It included only one study, and the risk ratio of this study is also significant, which is 0.30, which means 70% of the times their participants in whom skin-to-skin contact was done, they had prevention of neonatal hypoglycemia. So moving on, this two charts shows the effect of skin-to-skin contact on admission rate to any NICU for any reason, not particularly hypoglycemia, but for any reason. So the first A chart shows the results from randomized or quasi-randomized controlled studies. We see that the risk ratio is very high, which is 0.85. So this has little to no effect on admission to the NICU. And if we see the I-square also, it is more than 50%. And the bottom chart, or the B chart, shows the results from cohort studies, which mentions reports results from 3 studies. Here the odds ratio is 0.44, which is good, or they show good evidence against in favoring skin-to-skin contact, preventing neonatal admissions to NICU. So moving on, we see that the effect of skin-to-skin contact on admission to NICU, particularly for hypoglycemia, was studied only in one article, which was published in 2020, and the odds ratio of that cohort article is also 0.50. That is 50% of the times it was preventing hypoglycemia, and 50% of the time it was not preventing. So this did not show any significant statistical result. So to study the effects of skin-to-skin contact on hypothermia, all the studies that mentioned the result with respect to hypothermia was pooled, but the I-square, if we look, it is 82%, which means it shows a significant amount of heterogeneity. So a subgroup analysis was done to understand why there was so much heterogeneity, and it was found that infants who received skin-to-skin contact within the first 10 minutes after birth have an increased blood glucose concentration compared to infants who did not receive or in whom the skin-to-skin contact was initiated after 24 hours. With respect to hypothermia, a significant interaction between timing of skin-to-skin contact and hypothermia was established. That is, infants who received the skin-to-skin contact for at least 60 minutes or more had a lower incidence of hypothermia than the infants who received skin-to-skin contact for less than 60 minutes. Finally, all the evidences were compiled and they were reported in the form of grade assessment. We see that four main outcomes were taken for this grade assessment, which is neonatal hypoglycemia, NICU admission for hypoglycemia, duration of initial hospital stay after birth, and exclusive breastfeeding rate from birth to discharge. So on these four outcomes, we can see that low grade of evidence was seen with respect to neonatal hypoglycemia, and for all the other three, only very low grade of evidence could be generated. This was either due to a high risk of bias in their study, or attrition, or publication bias, and because of all this, the grade of evidence was either very low or only low. So evidence from some 7 studies suggested that skin-to-skin contact may result in a large reduction in incidence of neonatal hypoglycemia, and that it also reduces the incidence of hyperthermia and increases the blood glucose concentrations. It increases the exclusive breast milk feeding within the period of 3 to 6 months. But the effect was uncertain with respect to admission to NICU or admission to NICU for hypoglycemia, hypothermia. It did not have any effect on the duration of initial hospital stay after birth or in establishing the breast milk feeding from birth to discharge. So the strength of the study was that this was the first systematic review to investigate the impact of skin-to-skin contact on neonatal hypoglycemia. It included data from 84,900 participants, compromising evidence from almost 108 published studies, and it had a large sample of infants, and predominant of them were RCTs. It addresses the pre-specified outcome, which was neonatal hypoglycemia. It included studies from 38 countries, so the findings were likely to be applicable across many cultural contexts. Whereas if you look at the limitations of the study, not all studies reported the number of pre-specified secondary outcomes mentioned in the study, and there were no data on indigenous populations. Only 8 studies were conducted in low-income countries, so the data cannot be very generalized with respect to them. The risk of bias was high or unclear in certain domains. When many studies had unclear funding sources, accuracy of how the hypoglycemia was measured is not mentioned, and all outcomes with more than 10 studies had significant publication bias, and there was low certainty of evidence with heterogeneity for some outcomes, some of which was explained with subgroup analysis and some of them could not be explained. So PRISMA checklist, which is the preferred reporting items for systematic reviews and meta-analysis, was done, and it is a 27 item checklist, and when applied for this study, it was found that this systematic review fulfilled and was published according to this checklist. So the title identified the report as a systematic review. The abstract was as per the PRISMA's abstract checklist. They described the rationale for the review in the context of the existing knowledge that is so far available, and they provided an explicit statement of the objective regarding the objective in the review. They specify the inclusion criteria and exclusion criteria for the review and how the studies were grouped for the synthesis. They specified all the databases, registers, websites, and other sources that were searched, and they specified the date when each source was last searched or consulted. The full search strategies for all databases, including any filters, was mentioned, and specify the methods used to decide whether a study met the inclusion criteria, including how many reviewers screened each record and each report retrieved, whether they worked independently, and how, if at all both the reviewers had any issue, how that was sorted was mentioned. The methods to collect the data from reports, including how many reviewers collected, when they collected independently, was also mentioned. All the outcomes for which the data were sought were mentioned, and whether the study whether the study that they went through mentioned these outcomes was mentioned. All list and define all other variables for which the data were sought, like the participant and intervention characteristics, funding sources was mentioned as an appendix and uploaded separately. Specify the methods used to assess the risk of bias was mentioned as Cochrane's risk of bias tool was used, and the outcome for each measure, that is the risk ratio or the odds ratio, was mentioned. All the study reports and the processes were compiled and they were tabulated and uploaded separately as an annexure file. Any methods required to prepare the data for presentation, such as handling of missing summary statistics or data conversions, were mentioned. Any methods to tabulate or display the results of individual studies and synthesis was mentioned, and the subgroup analysis and the final summary table was compiled and presented. Any methods to explore the possible causes of heterogeneity was mentioned. Here they have used subgroup analysis, I-square test, and forest plot for this heterogeneity. Any sensitivity analysis conducted to assess the robustness of the synthesized results. So they could, as they intended, they could not do the sensitivity analysis because the all the published studies were of very low to unclear quality and bias. So that was mentioned in the article. Any methods used to assess the risk of bias due to the missing results in a synthesis. The results of the search and selection process, number of records identified, and finally the number of records included was mentioned. The studies that might appear to meet the inclusion criteria but which were excluded due to whatever reason was mentioned. Each included study and its characteristics was uploaded as a separate file. For each synthesis, briefly summarizing the characteristics and the risk of bias was uploaded. All the investigations for possible causes of heterogeneity was done. General interpretation of the results in the context of other evidence was done. Any limitations of the evidence included and the review process used was mentioned. And the future implication of how it could be done was mentioned. The trial was registered prospectively in the Prospero and the number was mentioned. There were no financial support for the review and there was no competing interest among the review authors. All this has been mentioned in the study clearly. Thank you.
Shalini,
Yes, ma'am.
very nice, very well presented. I think you should upload the slides. And the first 20 slides of yours is how to read a meta-analysis is very well done because it is not easy compiling multiple studies. The main issue with this meta-analysis was the study design was very different in different studies. They had included RCTs, quasi-trials, cohorts, case controls, and everything. That's why the heterogeneity of the trial was very high. Can you just put your first 10-15 slides quickly? They were
Yes, ma'am.
extremely, because these are the crux point which are going to tell us how to analyze a meta-analysis. Can you just put quickly?
Yes, ma'am.
Okay. Yeah, all this is fine. Proposed hypothesis you told. Next. Yes. The study design, how to read a. Yes, this is very, very important. Next to study design. PICO is very, very important. Before you design any study, when you are putting a research question in your mind, just has to be defined. This is the most important part of your study design. Next. So, and you also have to specify which babies in your PICO you're including, which you're not including. In systematic review, it also depends on what are the types of studies you're including in your systematic review, what are the types of studies you're outright refusing in your systematic. Next, so this inclusion and exclusion criteria is very important. So first is PICO, next is the inclusion exclusion criteria, and the three is what are the outcome you're going to find out from these studies. Only if these outcomes are there, you're including in your thing, in your this thing. So your outcome can be primary and secondary. Primary is the most important because your sample calculation will be based on your primary study in your individual study, but not in a systematic review. Next. Yeah. So the search database, everything she told very well. Next a few slides. Yeah, this is very, very, very important in a systematic study. Finally, how many they started, how many they ventured, how many they included, how many they excluded, and how did they arrive at this. They should have some format for this. If they are very clear about this format, then the final flow diagram will tell us exactly what is the number of studies they have included. Next. Okay, so see, highly heterogeneous, various types of studies they have included. That's why we are not getting that result which we wanted to have. Next. So this data collection and analysis, yes, it's been explained very well in the study paper itself. Next. Yeah. So this is very, very important whenever you're doing a systematic review and a meta-analysis, because you're compiling multiple study. You have to look at individual paper and see what is the risk of bias. This is a very, very important part of any study, and very well explained by Shalini about the how to avoid selection bias, how to look at performance bias, detection bias, attrition bias, and reporting bias. This is very, very important. If this bias is very high, then your study loses its value. Next. Yeah, so this is the pictorial representation of the risk of bias tool. This is so self-explanatory. Every study, what is the percentage of the bias they are having is explained by this. This again is an integral part of any systematic review. Next. Yeah, this grade quality assessment is also very, very important, and this was also very nicely explained. So unless your bias is low and your grade of assessment shows a good quality, your results you cannot extrapolate. So that is very important. Again, statistical analysis very beautifully explained in a meta-analysis what was the tool they used and what was the statistical method for various types of outcome and data was very well explained. And another important portion of a systematic review or meta-analysis is the heterogeneity of the study. If the study, and she explained the nice three tools for explaining the heterogeneity, which is very, very important. So first, if you're getting one result out of a meta-analysis, you think it is good, quickly go down on the bottom of the forest plot, you will get this heterogeneity, I-square value, chi value, and all that. And yes, the integral part of a meta-analysis is a forest plot. So she beautifully explained, this study explains everything. What are all the lines in a forest plot? How to read those lines? What is the weightage of each study, that it should not cross the line of null effect? And summation is the diamond which is seen either this side or that side. It's a beautiful. I think all of you should preserve these slides and keep looking at it whenever you're doing a meta-analysis study. Next. Yeah. So heterogeneity is very, very important. She gave all the three nice points of heterogeneity. Yeah. So this is what I wanted to emphasize. No, whenever you're reading a meta-analysis, these are all very, very, very important to understand these concepts, and then only you can start analyzing the meta-analysis. I think very well done by Shah.